Endocrine pathology, hyperthyroidism. For hyperthyroidism, honestly, the only one that we really care about is Graves' disease. Graves' disease is the most common cause of hyperthyroidism worldwide. You have to understand it. It's secondary to the fact that we have a thyroid-stimulating immunoglobulin. So once again, this is an antibody, but the antibody doesn't inhibit the process. It actually binds, and it constitutively activates the production of T3 and T4. It acts as if it's TSH. Okay, so it stimulates the TSH receptors and just constantly leads to the production of T3 and T4. So our overall TSH levels are actually going to be decreased because it senses such high production levels of T3 and T4. So the negative feedback loop is actually working very, very well. So you'll see very high levels of T3 and T4 and very low levels of TSH. Now, you have to know that the anti-TSH receptor antibodies are also known as thyrotropin receptor antibodies. Just keep that in the back of your mind. It's something that they can use interchangeably. The way that Graves' disease is going to present, okay, is going to be patients with Graves' ophthalmopathy, okay? Now that's just known as exophthalmos, and that's the bulging of the eyes. If you don't know what that looks like, look it up. It's very interesting. But what happens is that patients are going to have an increase in fibroblast secretion of GAGs, and it's going to lead to just an overall increase in swelling, inflammation, and that's what causes the exophthalmos. You also will have pretibial myxedema, and so that just means at the shin level, it's going to be like doughy, okay? So in front of, like, at the front of your knee where the shins are, or at the front of your leg where the shins are, if you press on it, you're going to have pretibial myxedema. It's just to be like doughy skin. They can also say, like, specifically lid lag. Lid lag is very associated with Graves' disease and hyperthyroidism in general. So keep that in mind when reading vignettes. Lastly, a very important thing that they love to ask about is that patients with Graves' disease, it does not improve when you give the patient beta blockers. The exophthalmos does not improve, okay? So what you're originally going to do to help treat hyperthyroidism, you're going to give the patients beta blockers immediately so that their symptoms can go away, because beta blockers are the first thing that you give for symptoms, for symptomatic relief. Then you can give them methimazole or PTU, obviously, if the patient's in the first trimester of pregnancy, but methimazole as well. But you have to give them beta blockers first. But that's not going to solve the exophthalmos. So you have to actually give them glucocorticoids in order to help solve the decrease in inflammation behind the eye causing the exophthalmos. Now, once again, that beta blocker provides the most rapid relief for adrenergic-mediated symptoms, which is seen in hyperthyroidism. And the two key features of Graves' disease, which is due to the increase in GAGs in the tissue, is pretibial myxedema and exophthalmos. So keep that in mind. The reason behind it is because of the GAGs, and you'll be good to go for hyperthyroidism. They like to ask about the Jode-Basedow phenomenon, and all that is that you're going to have iodine-induced hyperthyroidism. And so if I have essentially excess iodine, it's the opposite of Wolff-Chaikoff effect. So if I give a patient excess iodine, they will stop making T3 and T4 to protect themselves from hyperthyroidism, and that's known as the Wolff-Chaikoff effect. That's turning it off. However, the Jode-Basedow phenomenon is that I am giving a patient who is deficient for a really long time in iodine, I give them a huge bolus of iodine. Their body doesn't know how to react. And so I replete them with iodine randomly, and it leads to a hyperthyroid state. So keep that in the back of your mind. Next, I'll be talking about the thyroid cancers. They're relatively easy, but they're very high yield, so you have to know them. Number one is thyroid adenoma, also known as follicular adenoma. Okay, so I just call it follicular adenoma. And the one thing they want you to know about that is that follicular adenoma has no evidence of spread outside of the capsule of the thyroid gland. Very important. So follicular adenoma has no spread of the cancer outside of the thyroid or outside of the capsule. And the reason I'm telling you this is because I'm going to contrast it with follicular carcinoma. Follicular carcinoma, has evidence of spread outside of the capsule. It invades the thyroid capsule and the vasculature. It's very important to know that. Okay? And so you can't really distinguish between follicular carcinoma or follicular adenoma with just essentially a fine needle aspirate. You're going to have to do way more testing in order to differentiate. So they'll never ask you to differentiate. They'll just tell you what's the difference. Carcinoma can spread to the capsule and outside in the vasculature. Adenoma does not spread to the capsule and outside to the vasculature. And the way they remember that is that you take a car to travel out. So follicular carcinoma is going to spread out. That's how I remembered it. And the last thing, follicular carcinoma is one of those carcinomas, the exceptions, that spreads hematogenously. The next one is papillary carcinoma. Papillary carcinoma is the most common cancer, thyroid cancer. And it's the easiest to understand because there's so many trigger words, and it's the highest yield one. They love to ask about it. So what you're going to be seeing, make sure you know what orphan anti-eye cells look like on pathology, or on histology, I should say, because they will show you photos of it. They'll explain it. But if you ever see empty appearing nuclei okay, with finely dispersed chromatin is how they'll explain it, with central clearing. They're describing orphan Annie-I cells, and that is indicative of papillary carcinoma of the thyroid gland. You're also going to see psammoma bodies and nuclear grooves, and it has an increased risk in patients that had childhood irradiation, so prior radiation exposure. Very important. Make sure you know that. Everything that I said, really, really helpful. Lastly, medullary carcinoma is very important, and specifically it's associated with MEN2A and MEN2B mutations, and we'll talk about those later on in this chapter, but those are RET mutations. And what you have to know about medullary carcinoma is that it's from the C cells, but it produces calcitonin. So if you ever see calcitonin involved, they rarely ever talk about calcitonin. If you see calcitonin with sheets of polygonal cells and amyloid stroma, so you're going to see amyloid and calcitonin, then you know they're talking about medullary carcinoma, and it's associated once again with MEN2A and 2B mutations. Very important. So how are we going to see that amyloid for medullary carcinoma? Exactly. The Congo red staining, and it's positive for deposits. Okay, that's what it's going to show. Or apple green bifurcations. So keep that in mind for thyroid cancers. It's very, very important. They love to ask about it. And lastly, they love to ask about thyroid cancer post-surgery. So if they have removal of the thyroid gland secondary to thyroid cancer, the patients are at increased risk of hypocalcemia, a decrease in calcium. Because when you go and do thyroid surgery, you have an increased risk of removing parathyroid glands. And that will lead to an overall decrease in production of PTH. So that will cause hypocalcemia. So be aware of that specific complication of thyroid surgery secondary to thyroid cancer. They love that question. All right. But that's all for hyperthyroidism as well as the thyroid cancers.